for giving me this opportunity.
Dr. Ramesh Tigala and Dr. Yuvayar Yadav will coordinate with you.
Oh, great to see them here for the session. So the case I have been asked to demonstrate is a case of cerebrospinal fluid
Cerebrospinal
leak from the
fluid
nasal cavity.
leak from the nasal cavity.
This patient, this is a middle-aged female who presented to neurology department 6 months back with signs of meningitis and was treated on conservative basis. After that, she was discharged, and again after 3 months, she developed meningitis. Till then, no diagnosis of CSF leak was made. Then she presented to ENT surgeons. She had a history of intermittent watery discharge from the right nasal cavity, not continuous, intermittent, small watery discharge from the nasal cavity, and it was missed on all scans earlier. Then she came to us and we did a MR cysternography, and which I'm going to share with you, which revealed a defect in the right side, skull base, anterior skull base, which I'm going to show you. Can you connect the laptop, please? This is a very, very difficult situation, many a times, to pick up a small CSF leak. An obvious defect, traumatic defect is, not difficult to diagnose. Difficulty is when you have the patient with no continuous leak, no active leak, history of intermittent leak, your MR cysternography, CT scan may miss, if it is not fine sections, a small defect, and the patient remain undiagnosed many of the times and then present with meningitis. And we have certain, pattern of investigations to order in those difficult situations. So for this particular patient, the investigation we ordered was a MR cysternography. MR cysternography is nothing but then a high, heavily T2 weighted sequences. Heavily T2 weighted means, see this, let me give you different. This is T2 weighted sequence you can see everywhere. The bright sequence of the CSF, and rest of the sequences are not so bright. The brain sequence is gray. But in heavily T2 weighted sequence, what you see, the background is suppressed. Even the brain signals are suppressed, and the CSF and the fluid become more and more prominent in the suppressed background. So you can find even the smallest leak very, very obvious. So this is the, investigation of choice for us to pick up smallest possible CSF leak. And this is again done in a prone position to stimulate the leak at that particular time of, taking the MRI. This is absolutely non-invasive method. No contrast, nothing is given. And what do you find? You need to have the data in DVD rather than a printed scans that cannot pick up a dynamic, information. And this is how, let me tell you, from anterior to posterior if I go. I hope you are getting the MRI picture.
Yeah, yes, we are getting that.
So, sir, here I am going from anterior to posterior. See the bright signal of CSF everywhere, and the background of the brain is suppressed. See the fluid in the eye, which is prominent, and rest of the background is suppressed. And see, if I go from anterior to posterior, this is the, olfactory system. And what I see here, see this, see the bright fluid, the small droplet of the fluid, which has come in continuity from this, the CSF system. You can see that is the smallest, leak one can pick up. That is not possible on printed scans. See this, how thin are the sequences, 1.3 mm here. And you can see the same bright signal of CSF appearing to, coming down from the olfactory system, and this in continuity going down here as a bright signal. You can see very well. That is the smallest thing we could pick up in this case, and has been proposed for the, repair of the CSF leak. Has a history of intermittent leak from the right nose, history of meningitis twice, and now has come for the definitive treatment. You can imagine how difficult this to diagnose is.
So one small question to you,
Yes,
Jain
sir,
sir.
Yes, please.
How do you differentiate? Is a active leak at that time, or it is a collected CSF pocket within the maybe ethmoidal layer cells are the cribriform plate down.
Yes,
Because
that's a
if you see the
yes.
image clearly, there's no continuity between the cranial subarachnoid space to the
There is, sir. That's why I told you to have a dynamic imaging. See this, see
yeah.
this, see this. Dynamically, it is coming from there. That only can only be picked up by dynamic imaging. You can see in continuity, this is coming from the CSF space. This one. That is why the dynamic imaging important. We don't advocate to bring the imaging on printouts. That is how you can pick up easily. Now, your question is valid, whether it could be some mucosal edema, some sinusitis, or something else, or a CSF. How to differentiate? The only thing which can differentiate, though in a small leak, it is difficult, but in other cases, I will give you an example. In other situations, the investigation which we bring in together as a dynamic investigation is the flare imaging. 3D flare. 3D flare, in contrast to the heavily T2-weighted MR cysternography. Here in MR cysternography, heavily T2-weighted CSF is bright. But in 3D flare, the CSF is conspicuously dark. The CSF is conspicuously dark in 3D flare. So we compare these two images, but the CSF is dark in 3D flare, but the sinusitis is bright in 3D flare. So you can differentiate whether it is a sinusitis or a CSF. That is the only investigation, the only comparison which can give you or take you to the definitive diagnosis, whether it is a sinusitis. If, for example, if there is CSF leak here, it will be utter dark in the 3D flare. If there is sinusitis there on 3D drive or MR cysternography, it will be bright on 3D flare. So you can differentiate whether it is a sinusitis or a CSF leak. In this case, the leak is so small, you can't differentiate. You can't differentiate. I'll give you another example. See this. This is another example I'll give you. This is a different patient. See this. In this patient, the leak is here. Leak is here coming from the, olfactory space. See, this is the leak bright. Can you see in drive? Can you see this bright leak on drive?
Yes. Yes.
And see this bright is dark here in the flare. This is conspicuously dark here. That is classical of, confirming the CSF leak if you have these two sequences together on a digital format. That is something which can take you to the definitive diagnosis. So the bottom line is, we need to have a drive as well as 3D flare sequences. We need to have both these, on a digital format to run together to confirm each and every area. Now, there are certain areas, you see, there is certain other bright areas on drive, which are bright on flare as well. So these are all mucosal edema or sinusitis changes which can be bright on 3D flare, but on 3D flare, the CSF will always be conspicuously dark. So that is how you can differentiate between on imaging whether it is a CSF leak or a a sinusitis, and we need to have these two sequences together on digital format.
Dr. Jain, another question, whether it is, spontaneous rhinorrhea, or where in about 50% cases you have raised ICP. So that is very important to differentiate. And especially when you talk of intermittent CSF leak, the raised ICP and then it leaks and the symptoms are relieved. So whether during the relief there was intermittent headache or not, number one. Number two, what I see in imaging, that the subarachnoid space around the optic nerve is widened. So there is a suspicion of raised intracranial pressure. I think we should look for. And especially if there is partial patella, that it looks like in this case.
Yes. So your point is valid.
Your comments, please.
Yes. So spontaneous CSF leak many times is a manifestation of raised intracranial pressure, or what we call it as a benign intracranial hypertension. This is one of the manifestations. patient having benign intracranial hypertension, raised intracranial pressure can have, leaks somewhere as a manifestation of high pressure from the area which is very, very weak, congenitically, anatomically, whatever. So we see such leaks very common in high intracranial pressure patient where the bone or the skull base is very thin, like lateral recess of sphenoid, cribriform plate. Those are the common areas where easily those areas which give way easily due to high intracranial pressure. So how can you ascertain, like sir mentioned, you can have symptoms like, you see this subarachnoid space is replacing the sella partly. This is empty cella, partial empty cella, you can say, where the contents of the cell are pressed below and the subarachnoid space, this pouch containing the CSF is pressing into the cella from the diaphragm. This is one of the manifestation. Another manifestation, like sir said, because this CSF space is in continuity with the sheath of the optic nerve. And in those situations, this optic nerve sheath is tortuous and dilated. You can see here the optic nerve is tortuous and this CSF space around the optic nerve is little dilated, not very high. We have seen in cases where it is extremely dilated. It can rather lead to flattening of the globe from behind in extreme pressures, situations. So there are certain signs we need to know. This is the Meckel's curve. Many of the patients of raised ICT, we see the dilated Meckel's curve. Meckel's curve is nothing but the fluid containing space where the trigeminal nerve traverses. So we can see many other indirect symptoms of high intracranial pressure in those patients, and we need to be very careful in picking up this situation and explaining to the patient, because this leak can be a manifestation of high pressure. The moment this leak is releasing the pressure which is built up inside because of the lack of absorption or some other reasons. So we need to explain our patient closing the CSF leak can again lead to buildup of the pressure, and we have to monitor the pressure post-operatively to prevent the recurrence of leak or leak arising from some other space. So your point is valid, sir. We have to be very careful in picking up signs of intracranial pressure and to treat them post-operatively and convincing the patient accordingly.
Sir, same question continuity. If you think that there is a raised intracranial pressure, the simplest solution will be to do a CSF diversion, because many leaks stop with the CSF diversion. It's my personal observation as well as the literature review says that if a case of CSF leak secondary to the raised intracranial pressure or benign intracranial hypertension, one of the simplest solution will be to do a thecoperitoneal shunt that will stop the leak as well as the patient's symptoms will also get relieved. In a case of BAH, if you do a CSF, repair the CSF leak, the symptoms of BAH to persist. That is one of the cause for recurrent leak. Secondly, the headache and other raised ICP symptoms will not get relieved with your repair of the cranial defect. What is your say on that?
Yes. So our approach to dealing with the high pressure is little different, sir. What we do in such high pressure cases, see, as long as the CSF is leaking, and before surgery, if we do any puncture or anything, we may not find the high leak very, very clear. So what we do, once we seal the defect, like today we are sealing, after 24 hours of surgery, let the CSF pressure build up again back to normal. CSF is replaced almost 5 times a day. The volume of CSF is 150 ml, and the CSF secretion is almost 500-600 ml per day. So in 24 hours time, we allow it to replace the volume and build up the pressure, whatever it was, back to the previous level, and then we do a LP in high pressure situation. If our pressure that time post-operatively is too high, if it is about 30 or so, then we have to take something, some sort of intervention immediately. If it is not that much, then we can control on the conservative basis, on the basis of, regular examination, regular fundus checkup, symptomatology, and other things. If the pressure is too high and the chances of, leak coming back, chances of symptoms of intracranial pressure persisting, then you can think of diversion procedures. Number two, in all these patients, our policy is always to get a venogram done, MR venogram done, and many a times we have found the stenosis of the venous sinuses. The CSF circulation is such that the CSF is absorbed in the arachnoid villi, and most of the time it is a fault in the absorption process which is leading to the high pressure. And we have couple of cases in the last couple of years wherein we found the venous sinus stenosis led to the high pressure, and two or three patients now, we have done the venous sinus stenting to relieve that pressure and getting the CSF pressure back to normal. So the cause behind that sometimes can be different, and CSF diversion procedure is something not always needed, but yes, it is one of the important tool in tackling the high pressure in selected situations.
Yes, please go ahead. Thank
Sir.
you.
So there are, I will show you some of the venograms if I get now. This is not the venogram. So any other question before we move on to the surgical part, sir?
I think you have covered things very well. You can. Any other question? Yeah.
Sir, good morning. Sir, before sir we go ahead, sir, we have to find out what is the defect side, because the defect in the bone. So that's why it's requires CT, sir.
Yes. Yeah, we had a CT scan printout before. The patient had got done several times earlier, not on DVD, and we those CT scans were not fine sections, and there was hardly any defect seen. So it is not uncommon to see CT missing a small defect in the ethmoidal roof, and yet there is a CSF leak. Only if you have a 0.5 mm fine section, that too on digital format, you can still pick up. But that opacity of the CSF and the opacity of the mucosa and the sinusitis, you cannot differentiate unless you have a big defect through and through. Unless you have a big defect through and through, you can't pick up. I can give you example. I had given example yesterday in my talk as well as I'll just tell you. See this. If you have an obvious defect, you can pick up easily. But if you have a small defect, even your CT can miss. And one of the investigation in the intermittent and most difficult situation, let me enumerate here for all of you, is our investigation of choice in most difficult CSF, diagnosing most difficult CSF leaks, particularly intermittent small leaks, is the contrast enhanced MR cysternography. What is contrast enhanced MR cysternography is? It is not CT cysternography. CT cysternography you are seeing here. What I am talking is a contrast enhanced gadolinium enhanced intrathecal gadolinium enhanced